Great, so welcome to our third and final session of our Behavioral Health Community of Learning series, Strengthening Wellness in Indigenous Communities Using the Medicine Wheel. We're delighted to have you all here today to learn more about culturally responsive care for sexual assault survivors. In this webinar, you will gain invaluable insights into several key areas, which we'll learn about shortly. We are also so fortunate to have amazing speakers with us today, Nicole Stahlmann and Billie Brown from Indian Health Services. But before we begin this introduction, I'd like to introduce some of our team from NCUE helping us today. My name is Liz Best, and I'm a program manager of technical assistance with the Technical Assistance Research Center, known as TARC. And joining me from the NCUE team are Molly, Public Health Associate. We have Alyssa Longi, who is a Public Health Program Manager, Jessica Gilbertson, Director of Communications, and Zoe Harris. We are honored to have you all here today, and we kindly ask that you place your name, your organization, and your tribal affiliation and title into the chat box. In addition, we welcome any feedback you would like to provide about your webinar experience today in our survey, which we will also post in our chat box and have some time to complete at the end. Next slide, please. For those of you who are not familiar with NCUE, if you're joining us for the first time, the National Council of Urban Indian Health, also known as NCUE, is the national nonprofit organization devoted to the support and development of quality, accessible, and culturally competent health and public health services for American Indian and Alaska Natives living in urban areas. NCUE is the only national representative of the 41 Title V urban Indian organizations, or UIOs, under the Indian Health Service in the Indian Healthcare Improvement Act. NCUE strives to improve the health of over 70% of the American Indian Alaska Native population that lives in urban areas, supported by quality, accessible healthcare centers. Next slide, please. We wanted to share that this event is made possible today by the Indian Health Services. However, this event is solely the responsibility of the National Council of Urban Indian Health and does not necessarily represent the views of Indian Health Services or the Department of Health and Human Services. Next slide, please. So before we get started, just a few housekeeping items. Please note everyone's mics have been muted upon entry. We always encourage participation and engagement, and we invite all the participants to turn on your camera, post in the chat questions or comments along the way. There will also be an interactive activity at the end of the presentation and an opportunity for Q&A at the end of the program. Next slide, please. Please note that this session is being recorded for educational and quality improvement purposes. The recording will also be shared, as well as the slides, after the program, in case you missed it or would like to revisit content at a later date. Since this topic may bring up past trauma, we will stop the recording before our Q&A to allow for a more open space. No information will be shared other than the slides being recorded. Next slide, please. As we continue our webinar, we encourage active participation and value your questions and insights. To make the most of this interactive experience, here is how you can ask a question on Zoom. Just click on the chat icon, type your question, and hit enter to send it to the group. We will also have a breakout room for anyone in need of emotional support or needs to take a break. For access to this room, please message Molly Siegel or Zoe Harris in the chat, and you will be brought to a separate room. Next slide, please. And the next slide, please. So I'm super excited to introduce our speakers today. Nicole Stahlmann serves as the Forensic Nursing Consultant with the IHS Division of Nursing Services. Prior to her work at IHS, she served as a Forensic Nursing Specialist with the International Association of Forensic Nurses, and she was the Clinical Program Manager for the District of Columbia Forensic Nurse Examiners. Ms. Stahlmann was an emergency department nurse and adjunct instructor teaching both undergraduate and master's prepared students at Georgetown University. She continues to practice clinically, providing care for patients who have experienced violence. We also are very fortunate to have Billie Brown here, Aaniiih Nakoda of the Fort Belknap Indian community in north central Montana. She serves as the Forensic Nursing Coordinator with the IH Division of Nursing Services, Office of Clinical and Preventive Services. And prior to her work with IHS Forensics Healthcare Team, Billie served in various nursing education, and leadership roles with rural tribal communities. This service has included work with Montana tribal colleges, along with IHS tribal and private healthcare organizations on the Fort Belknap, Northern Cheyenne, and Crow reservations in Montana. And without further ado, I will pass the mic over to Nicole and Billie, who will share their insights and experiences with us. Thank you.
Thank you, Liz. Just checking that you can hear me again. Yep,
yes.
Perfect. Okay. I just wanted to say hello and welcome to all of you. Thank you for joining the session today. And then also thank you to Nikui for inviting us to speak on forensic healthcare. We certainly appreciate this opportunity to share culturally responsive care for sexual assault survivors. So in this next slide, you'll see here our learning objectives for the session. And Billie is going to provide an overview to support gaining a basic understanding of the Indigenous medicine wheel, center direction of healing. We will provide insight and understanding to the high rates of violence and sexual violence against American Indian Alaska Native women. We will discuss stigma and additional challenges that survivors of assault face with barriers to care and how how culture can reduce stigma and address barriers. Understand the importance of expanding culture in culturally sensitive, emotional, and mental health services to sexual assault survivors to reduce that stigma and address barriers. Implement efficient ways to build, monitor, and evaluate forensic healthcare programs working with missing and murdered Indigenous people. And then wrap up the meeting to discuss best practices for coordination of care using a multidisciplinary team approach. And as noted by Liz, we're also going to talk about or have an interactive session at the end of this these slides today. So we'll go on to the next slide and Billie will start us off.
Good afternoon. Are you able to hear me?
Yep, I can hear you.
Awesome. Naha ni nostekin, ni naha ban, na nisa it's ita ite. Ni nano Aaniiih and Nakoda. Ginihan. Good afternoon. Greetings today. I'm happy to see everybody here. We give our thanks, as Nicole says, for the invitation and the time to share. My name is Billie Jo Brown. I am Aaniiih and Nakoda. I'm from the Fort Belknap Reservation communities in north central Montana. As we look at the medicine wheel here today, and before we get started, I want to just give my apologies for my IT problems. I'm not able to get my camera settings switched over for Zoom somehow. So moving forward, we look at the medicine wheel. This medicine wheel is common to many different, all the different American Indian tribes. It has unique variation in meaning, as well as configuration for each group or individual. This image showing on the screen today is an image of the medicine wheel that's been used to articulate the cultural foundations of nursing care and as well as the education of nursing students as we prepare them for providing quality and safe care to individuals from any culture or background. Within the medicine wheel, the circle represents a cycle of life and all of the interrelationships for all aspects of life and ways of being. The holistic and the balanced nature of these life ways or ways of knowing really are incorporated throughout all parts or all areas of the medicine wheel. How does the medicine wheel relate to healthcare? As we provide healthcare, we want to make sure that it's patient-centered care. The healthcare team or the organization must consider the whole person. We consider their culture, their environment, and the individual or the group's history. In this perspective, the intrinsic holism of the medicine wheel really can be utilized to guide our work as healthcare providers with individuals, families, or communities. I did reference Margaret Moss. Margaret Moss is a nurse leader from the three affiliated tribes of North Dakota, Mandan, Hidatsa, and Arikara. She's also Canadian Sioux. And as a Native nurse and nurse leader with a PhD in nursing and a Juris Doctorate, as a nurse leader, she was published in 2016 as the editor of maybe one of the first textbooks in nursing and healthcare that's specific to American Indians. In this textbook, she had a very eloquent description of how these holistic characteristics or the dimensions of the person demonstrated by the medicine wheel really align with nursing's 4 pillars or elements of care. We look at the health of the individual as a continuum. The role of the nurse is to facilitate care. When we look at the person, we consider the whole person, and we also look at the environment in terms of all factors that affect the health of the individual or a population. If you follow the listing in each quadrant, you'll see that each direction is represented by a color, a season, and an element. If we follow from the east with the spring season, you'll see that we relate that to infancy and early childhood. You'll see that each season correlates also with the developmental stage of the person and a dimension of the person or the being. And in this, we have our physical, mental, emotional, and cultural. As these seasons and stages of the developmental cycle with the sun and the direction of the clock, these concepts of the person really are comprehensive and holistic and cross over throughout all of the seasons and the stages of development. So we follow from the east and go through the south for summer, adolescence, or young adult stage. In the west, we have the adult and maternal stage. And in the north, we look at our elders. And all of these stages, definitely are not black and white in terms of when they are reached and how the person processes through. And then again, our physical, mental, emotional, and cultural elements are really across all areas of the person. As we're looking today at forensic healthcare, we remember that forensic healthcare provides services to individuals that are affected by violence, domestic violence, intimate partner violence, sexual assault, elder or child maltreatment. Especially for these individuals that are affected by violence, we want to make sure that we take a holistic approach to the prevention and care at every level of these patients. As a healthcare facility, this really includes connecting with our community partners, forming teams, and working together for community prevention. We want to make sure that we provide holistic care for our patient throughout the healthcare response, the criminal justice response, and all of the follow-up for our patient, making sure that we're able to restore the individual's health and also considering that individual's family as well as the community. You'll see in the future slides that we discuss all of these community partners. We have the mental health, behavioral health, social workers that may or may not be internal to your facility. We want to work with law enforcement, our local tribal advocacy teams, the prosecution teams, our crime lab personnel. We want to also include all of our adult protective services, child protective services, and our local, state, and tribal representatives. As we work with the patient, we want to establish trust within our community. So as a facility, when we establish this trust, we also have culturally appropriate screenings. And throughout the process, we provide a culturally safe environment that really responds to all dimensions of the individual or the person. As part of our medical forensic care, we provide education to the patient throughout every step, making sure that the patient is able to make informed decisions regarding their care. The patient is always in charge of their care. We as a healthcare team are facilitators. We make sure that the patient's wishes are followed at every step of care, and we ensure that patient consent is confirmed. We want to make sure that we have warm handoffs amongst all of our partners. This ensures safety of the patient, but also ensures the patient is able to access all of those resources and the follow-up in their continuum of health. As a urban facility, we understand that every facility may not have the ability to have a fully operational forensic healthcare program, but definitely we can ensure that facilities offer our services in collaboration with our community members to meet the needs of our patients that are affected by violence. Throughout the remainder of today's presentation, we'll be able to follow back and make alignments or see the alignments with the medicine wheel as forensic healthcare supports the health and the healing of our patients, our families, and communities. Excuse me, sorry about that. And so really with that, we can turn on to the next slide.
Really quick, can you go back to the statistics slide? I think we advanced one too many. Okay, so we're missing the statistics slide, but I'm just going to go through and read some statistics for you. There we are. Okay, perfect. I just want to say thank you, Billie, for that overview. That was a great overview of the medicine wheel. And like she had mentioned a few times, we're going to go through, as we go through our session today, we will definitely pick up on various pieces that link back to that medicine wheel, certainly highlighting approaches such as caring or spiritual protections or truly healing on that large scale holistic approach to patient care. And then I really wanted to say before we start on the statistics, I just want to make a quick note that this material can be heavy. It can be somewhat disturbing to some people, maybe traumatizing, and certainly can be triggering to some. So with saying that, please feel free to jump into that other breakout room at any point or as you are as needed. And lastly, we are in this virtual world, so it's important to recognize and protect other eyes and ears that could be in our immediate space, or recognize that this material is not necessarily for everyone in the room. So just as we go through in our virtual world. Perfect. All right, so we're going to start the session today with a few statistics on violence. So beyond numbers, beyond data, the most important key takeaway is that violence does not discriminate, and it certainly is a relentless plague that plagues everybody across the lifespan. And statistics alone do not capture the actual depth of individual and familial historical trauma and oppression, including violence experienced by tribal communities all across the country. So according to RAINN, the Rape, Abuse, and Incest National Network, every 68 seconds, an individual in America is sexually assaulted. That's every 68 seconds, just nearly every minute. Concerning, right? Over half of women and almost 1 in 3 men have experienced sexual violence involving physical contact during their lifetimes. 1 in 4 women and about 1 in 26 men have experienced completed or attempted rape. More than 4 in 5 American Indian and Alaska Native women, or roughly about 85%, have experienced violence in their lifetime, and 56% accounts for those who've experienced sexual violence. These are incredibly high percentages, and something that we're going to talk about in a few slides. So the third bullet, or the fourth bullet here, American Indian and Alaska Native women are 1.2 times as likely as non-Hispanic white-only women to experience violence in their lifetime, and 1.7 times as likely to have experienced violence in the past year. The 2015 United States Transgender Survey reported that 47% of transgender people are sexually assaulted at some point in their lifetime. 65% of the American Indian 2S LGBTQ+ community reported to most likely have been sexually assaulted in their lifetime. And to have to say this, it's kind of silly, right? But statistics come with a margin of error. So in other words, statistics alone do not capture that true depth of trauma, often leaving multiple variables out of the equation. So For example, we often see patients who seek healthcare, but they're not reporting to law enforcement. So those statistics alone are kind of out of this equation. And more importantly, statistics that aren't captured here are the patients that are not even able to reach any type of service. So just some things to think about as we go through our session. On this next slide here, the insight to high rates of violence. Perfect. So the prevalence of violence is a vicious cycle, whether that person experiences violence or violent crimes directly or indirectly. It's a vicious cycle for everybody that's involved. It's a highly prevalent crime, and it's highly prevalent based on intergenerational trauma, historical trauma, and oppression, which we've said a few times now, but it's that ongoing and unjust treatment. It's a vicious cycle. And we will speak more on this in a few slides, but violence is a healthcare issue. And within the healthcare system, viewing violence as a healthcare issue remains a collective narrative that needs ongoing adjustment and constant vision for change. It's something that cannot remain status quo in our worlds. So at its simplest form, as simple as a lack of resources often equates to these high rates of violence. So oftentimes there's a lack of trauma-informed, patient-centered forensic healthcare for patients, for families, and for communities as a whole who are affected by violent crimes. There's a lack of transportation to and from one's home and to the hospital or clinic to receive services. There's a lack of providers trained to offer the medical forensic examinations. There's a lack of community advocates to ensure supportive follow-up services are available for patients. There's a huge lack of shelters, right, to ensure safe housing. There's a lack of understanding of this web of jurisdictional boundaries with reporting and legal requirements, which creates barriers to seeking or even engaging with the criminal justice system. There's a lack of community champions and prevention efforts. There's a lack of education and awareness around the topic. There's a lack of resources, safety, food, finances. This is a non-exhaustive list, I should say, but all of this leads to higher rates of violence. Health inequity, limited access to healthcare, increased adverse childhood experience or ACE scores, increased rates of youth and teen dating violence, drivers that are linked to morbidity and mortality, drivers linked to accessing and the misuse of drugs and alcohol, social determinants of health, COVID-19, just to name it again, because we are kind of sick of it, right? But to name it, we have to here, because these are all linked back to high rates of violence, and especially within our American Indian and Alaska Native communities. So all of these factors really drive high rates of violence. Oftentimes you'll see re-victimization with these high rates. So I know we're going to talk about this in a few slides, but it's important to talk about maybe a goal to decreasing the violence. And maybe it is that we would develop, use, or sustain harm reduction strategies, or enhance the pillars of health equity. So build those champions in your community, provide ongoing training and education for everybody in the community, enhance awareness throughout the community, ensure resources are readily available and accessible, include resources from members all across the multidisciplinary teams. And then what's important here is maybe that we're talking about hosting conversations with everybody involved. And then even uphold tribal self-determination. So ensure that tribes are controlling their resources or their own resources, their policies and procedures, certainly their goals and plans, each rooted in strength, resiliency, and even identity. On this next slide, there we go, perfect. So victimization is unique and it's a highly personal crime. There is not any one particular presentation of any patient, survivor, or victim that comes through our doors at any healthcare facility. The stigma and some of the barriers to accessing healthcare following violent crimes include the patient and or families lacking trust within the healthcare system, as well as that criminal justice system. And this links back, certainly relates to historical trauma and oppression, like we've talked about, intergenerational trauma as well, excuse me. The patient, victim themselves, they have a fear of being mistreated. They have a fear that their assault or injuries will be minimized. They have a fear of not being believed, fear that friends or family will find out about their assault, especially if their friends or family work in that same facility where they're going to receive that care. You'll see the animated box that's going to come up next. It's a blue box at the bottom of the page. There it is. So just a few other items include anger. So the patient may have anger with the system. They may have anger with themselves, or even that perpetrator or assailant, whomever assaulted them. They feel shame, guilt, or distrust. They sense that they are not believed. Maybe they have self-blame for the assault. They feel like a hindrance to their loved ones. And you'll see this especially with our elders or our elder population. They feel as though they're a hindrance if they say anything to anybody. They may feel embarrassed that they're all alone and they don't know how to navigate the system. They could simply feel like they're okay and they lack physical injury and they self-downplay their injuries. So maybe another reason why they're not seeking services. Again, we've said this a few times, but a lack of resources, and a lack of resources, including systems and community-based advocacy agencies, primary healthcare and follow-up healthcare for all of our patients. There are barriers that include financial issues or transportation issues, getting to and from that healthcare facility to obtain that care. There's a lack of trained providers. So there's a lack of sexual assault nurse examiners, sexual assault forensic examiners, sexual assault examiners, or FNEs for forensic nurse examiners, some acronyms on the bottom bullet there, but a lack of trained providers to offer that trauma-informed medical forensic exam. So all of these barriers can and will ultimately lead to re-victimization of that patient, again, linking back to that vicious cycle of violence. So I'm going to pass it back over to Billie to talk more about expanding culture to reducing stigma and address barriers.
Thank you, Nicole. Okay, so when we look at expanding culture, really cultural knowledge, cultural information, and having a perspective that our culture really is what's driving all of the areas for our healthcare system. We really look back and kind of look at the idea of what is culture, how do we define culture? And that's difficult within the English language for a lot of individuals. And as we looked at the medicine wheel, we really look at everything holistically. We want to include all of the traditional values, beliefs, teachings, all of the medicines or healing ways, and the ways of being. I want to make the comment that we understand urban facilities often serve populations that are from more than one tribal group. We want to highlight the fact that each of the 574 or additional tribes may define culture or have elements that include different components because of their geographical locations, because of their histories. And culture really is a fluid and flexible concept as we understand the people, and even as we work through different areas of time from looking at traditional versus contemporary. So kudos go out to our forensic facilities, our urban facilities, excuse me, as they work with individuals that come from different cultures. When we look at expanding culture to reduce the stigma and address all of our barriers, We want to really allow and support our facilities to incorporate all of these traditional values, beliefs, teachings, and ways of knowing. Incorporate individuals from the community, incorporate your staff members to include resources and individuals to bring in to share cultural components. We want to highlight our strengths and resiliency of all of our communities. And this includes individuals as they are navigating different geographical areas. Our advocacy is really important, and advocacy for ongoing and dedicated education and training related to not just cultural competency, but really looking at cultural in terms of cultural safety and what that means for the provision of our cultural care that is safe. Taking that next step of what does it mean just to be open to an individual and understand that we may not know specifically everything about an individual, but being open to them will provide a safe environment to make those connections. The other component is also looking at clinical training and education. We really need to make sure that we have all of our medical, nursing, and skills and information, skills and knowledge related to the healthcare system down, because when we have those competencies maintained, then we're able to really focus and deal with meeting our people and dealing with the people side. And this is for all levels of medical providers, our nurses, our advanced practice registered nurses, and our medical doctors, and all other levels of providers. The other part of culture is really looking at looking at it from a program perspective. What are our networks? Utilizing our community partners, collaborating with our community partners locally and in our geographical areas to cover the individuals that we serve, and making sure that these resources are available for patients, making sure that the community partners we are reaching out and working with also have knowledge of the cultural safety and can meet the needs of our patients, helping our patients navigate these systems. So community-based services to reach our patients and also help them support that transition of care from our facility into those areas that we refer our patients to for additional cares. The other component is making sure that we ensure best practices for prevention services. That includes primary prevention, so education and awareness in our communities, and then also secondary and tertiary prevention. And as we mentioned already, we always want to look at minimizing our re-victimization of individuals as they come to us for care. Next slide, please. So the next slide looks, we'll go back one. Oh, no, we're right. So implementation as we work with our MMIP patients. So missing and murdered Indigenous women, missing and murdered Indigenous relatives, or missing and murdered Indigenous persons. So we haven't opted to address this as MMIP, including all of our partners, community members, women, relatives that are have gone missing, murdered, and have been affected by this. So as a healthcare facility, we want to create a readiness assessment checklist. Within our forensic healthcare programs, we identify our program infrastructure and personnel. We identify and build champions, whether we have a full forensic healthcare system or we're offering services that meet the needs of our patients affected by violence. We can have champions within our facilities that help our teams work through and set up our screenings, all of our collaborations across the facility, etc. We want to develop systemic policies and procedures, offer ongoing training and education, make sure that we have this training and education includes not only the healthcare providers, but all of the ancillary team members. So those individuals that are answering our phones, those people that are taking appointments, the front desk clerks, our billing office, our coding offices. In terms of the medical care, we want to make sure that all of our supplies are stocked. We have equipment that's functional, and we want to make sure that our equipment is maintained continuously. We want to expand our services, introducing trauma-informed, culturally appropriate screenings, and making sure that we have the resources available to react to positive screens. We want to network with our tribal coalition and advocates to ensure that our proper resources are available upon discharge, making also those warm handoffs. And if we are not able to make connections with a specific tribal coalition, we want to make sure that our local coalitions and our advocates are aware of our patients' needs, and we have the warm handoffs to make sure that our patients don't fall through the cracks. Looking at the system, we want to conduct preventative outreach and training activities and connecting with our communities. This can include local schools, our recreation centers, our gyms, and other health clinics, all of our community events, and just getting out in the community to make sure that we're providing awareness and education. In terms of our multidisciplinary approach, you'll notice we talk a lot about connecting with our community partners, incorporating all members of our multidisciplinary team, our sexual assault response team, our coordinated community response team. These are three names that a lot of our multidisciplinary teams may take, and they may already be in place, and a lot of our facilities are already part of these teams. We want to include education, understanding of our policies, making sure all of our policies align with our coordination of services with our community partners. All of our procedures, the roles and responsibilities are clear. And then we also want to, for quality, make sure that we conduct peer review to ensure we are maintaining quality assurance. We're making sure our services are trauma informed and that we're providing comprehensive wraparound services to our patients at all levels. And so that really addresses some of the issues that we're looking at that affect our facilities' abilities to provide care for these patients that are affected by violence. We can go to the next slide. So this next slide is really introducing us to the next part of our presentation. We're going to discuss best practices which guide our practice within the Indian Health Service. Next slide. As we go back to, as I hand the mic back over to Nicole, we also wanted to just make the point again that from a medical forensic standpoint within the Indian Health Service, violence really is a healthcare issue, and we want to approach violence as a healthcare issue. And so I'll hand the mic back over to Nicole, and we'll begin our discussion of best practices.
Perfect. Thanks, Billie. We can go to the next slide. Awesome. So just like Billie mentioned, and as we had mentioned a few times now, that violence is that healthcare issue, we want to make sure that we're following best practices to ensure that we're offering that quality healthcare. And as best practice is about providing a holistic approach to preserving the life of our patients, providing the patient with the healthcare that they need and that they deserve to rebuild and regain their life to their normal state. And this being following a traumatic event, right? And I keep emphasizing there because it truly is their approach to their healthcare and how they are going to rebuild and regain their life. And every single patient is very unique and very different. So everybody's normal is going to be very different in this approach as well. So IHS strives to ensure best practices are followed by healthcare providers as it relates to forensic healthcare. And the exam is tailored to the specific circumstance or the situation based on that patient's assault narrative. And the patient assists in making decisions and is the one who is ultimately in control of the examination. So everything that we do is done by the consent of the patient. And to support and guide our practice, the sexual assault nurse examiners, the forensic nurse examiners, or sexual assault forensic examiners, really, again, that acronym, it's just based on the role or the title of the individual. It can, it's more of an umbrella, if you will, for nurses, for providers, for PAs, for advanced practice nurses. But anyways, we have access to a variety of best practices, and a few of those are listed here. So we practice by the Indian Health Manual, Part 3. So Chapter 29 covers sexual assault. Chapter 31 covers intimate partner violence. We also practice to the National Protocol for Sexual Assault Medical Forensic Examinations. It's the adult, adolescent, as well as pediatric protocols. And newly released this year is the National Protocol for Intimate Partner Violence and Medical Forensic Examinations. We also have the National Best Practices for Sexual Assault Kits, a multidisciplinary approach. Not listed here, but something that we certainly practice to as a core curriculum, as well as the Forensic Nursing Scope and Standards of Practice. Our recently posted medical forensic healthcare guidebooks. I say guidebooks because we have a second one that's going to be available soon, but those are available on our website. Training, education, and technical assistance from the forensic healthcare team. So truly, any kind of technical assistance that you guys have or that you have questions about, we're here to help you, but also build and learn from you as well. Additional resources, webinars, toolkits, and committees that we engage in, and of course, the entire multidisciplinary teams that we collaborate with, all link back to best practices or ensuring that best practices are being followed. And I'm going to pass it back to Billie for the next slide.
All right, thank you, Nicole. So continuing on with best practices, we really want to make sure that we emphasize a trauma-informed approach. And this really does go back to the medicine wheel, as well as looking at holistic care across the continuum for all of our patients. So we emphasize again the importance of trauma-informed. We consider the impact of trauma, as well as the patient's or the victim's safety. Again, looking at the physical, mental, emotional, cultural, and spiritual components of the patient. The use of trauma-informed approaches really place an emphasis on the following elements. Again, we look at screening, making sure our screenings are appropriate for intimate partner violence and domestic violence. We look at sexual assault screenings and human trafficking screenings, as well as abuse. We always want to attend to the patient's whole needs, including emotional safety, as well as their physical safety. We strengthen patients' capacity throughout to allow them to recover from the traumatic effects, of abuse and violence. Doing so by providing information, resources, services, and support. And this includes our collaboration with our community partners. We always want to educate our patients, educate our service providers, and the communities about our impact of trauma, how this relates to patient or the survivor's health and well-being throughout all levels of our care, and incorporating the holistic approach to our patient. Not only medical providers, but all partners, such as our advocates, our law enforcement partners, our prosecutions, etc. Really together as a team, we want to make sure that we're providing a trauma-informed approach to all of our work with our patients. Trauma-informed care implies an understanding of the local culture, as this is necessary to really understand the historical trauma that affects the local community. And so there's a lot of ways to be creative with this. And again, it takes a continual effort to keep this information at the forefront and always keep it a reminder as we look through our quality assurance processes, in our peer review processes, and supporting our facilities and our healthcare providers as we work together in providing this care, because it really can be heavy care for heavy on our providers as well. And as we go to the next slide, we'll give it back to Nicole.
Thank you, Billie. So on this slide here, really it's just an overview of the medical forensic exam. I just wanted to highlight here that for the programs that have the capacity to offer medical forensic healthcare and related services, we should be instilling that we're formulating a care plan with the patient. So it's not just our decision as healthcare providers to say, hey, this is what we're doing, but rather incorporating that care plan with the patient. So again, this slide highlights the exam, what it includes, but certainly what it's not, definitely it's not limited to, if you will. So we obtain the patient's consent to conduct the exam, and every single patient, we obtain their written as well as verbal consent, and this is on a continuum. After that consent is obtained, we obtain the medical forensic history, which includes a past medical history as well as that patient narrative of what happened during the assault. After that, that narrative truly guides our medical forensic exam and that physical assessment. So we will conduct a head-to-toe exam, or it certainly can be focused just given that patient's narrative or based on their request. It just really depends on that patient. And again, no two patients are alike, so every exam is very different. This physical assessment will also include documentation of any findings and photographs of any findings. The head-to-toe exam will include a detailed anogenital examination, and that's going to include the use of a speculum to visualize the vagina. And this is to identify any potential injuries or findings, as well as collect evidence. The exam will also include the use of an anoscope to visualize the rectum, and again, collect evidence if needed. We're going to collect forensic evidence. Anything that we find, we're going to use that sexual assault evidence collection kit. Treatment options, those can include, for example, sexually transmitted infection prevention medications, emergency birth control, HIV prophylaxis, hepatitis B immunization, maybe a tetanus if they need it, pain, and certainly nausea medications. And then our exam certainly includes that collaborative referral or resource. That includes behavioral and mental health services, as well as advocacy services, in that coordination with the criminal justice system if the patient's not already involved and if they want to seek those services. And then, of course, discharge teaching and safety planning. The box on the right of the screen outlines the purpose of these exams within IHS, and the purpose is to provide a safe, trauma-informed environment for that patient in their exam, and for there to be a possible disclosure of that assault. Another purpose is to provide quality medical care. Another is to allow for the opportunity to educate on health effects of intimate partner violence, domestic violence, sexual assault, strangulation, among other victimizations, if you will. And then certainly offer resources that referral safety planning for that patient. The end result is to support the patient and their needs, certainly to minimize any potential health consequences that they may gain or pick up just based on this victimization or this traumatic event. And then our last slide here, I know we're running out of time, but I'm going to pass it back to Billie to talk about best practices.
Thank you, Nicole. So we've already mentioned a lot of the different components, but we really want to focus on our participation in a multidisciplinary team, whether that be a sexual assault response team or a community or coordinated community response team. So all of our federal, tribal, or urban facilities, our forensic examiners would be a part of that team. We want to include and make sure that we have our behavioral health, our mental health team, and our social workers, tribal advocacies, whether it's community-based or it may be a system-based, it may be a regional advocacy program as well. Law enforcement, looking at our jurisdiction, that can be local, tribal, state, FBI, BIA, etc. We also want to have our prosecution team involved. We want to be in contact with our crime lab personnel. And a lot of our states have the sexual assault kit tracking programs. And then also our crime lab can work with our teams for quality assurance in the evidence area. Adult protective services, again, and child protective services are important to have involved. And then also looking at the policy level is having involvement with our local, state, and tribal representatives. Our collaborative work, really we want to build together to build policies and procedures around the response, understand the roles and responsibilities of all of the team members, including our jurisdictional boundaries, and draw professional connections. Okay, and so we can go to the next slide, which takes us to our, go ahead, Nicole.
Yeah, I was just going to say we're at the Q&A and we can probably jump over to the Padlet questions, Liz, if that's okay with you.
Yeah, so thank you so much, Nicole and Billie, for this important and comprehensive overview. We're going to transition into